What's good, folks? It's Handsome Nerd ASMR back with another video. In this video, I'm going to be explaining about the difference between afferent and efferent arterioles. So why bother learning about the difference? Well, it is important in the context of renal physiology and pathophysiology. And they are not just your typical blood vessels. They are actually dynamic regulators of glomerular filtration rate and renal blood flow. So they are central to understanding kidney function, pharmacology, and disease states like hypertension and acute kidney injury. Let's kick things off with the basic anatomy and flow path for these arterioles. So, the afferent arteriole, which begins with the letter A, will deliver the blood to the glomerulus. And the glomerulus is a network of capillaries in the nephron, where the filtration begins. By the way, the nephron is a functional unit of the kidney, and this is what it typically looks like. It is responsible for filtration of our blood and ultimately the production of urine. So that's the afferent arteriole. The efferent arteriole, which begins with the letter E, will drain blood away from the glomerulus. Rather than simply exiting the kidney, it continues into the peritubular capillaries, as shown over here, or the vasa recta. So, it will continue into the peritubular capillaries if we are in the cortical nephrons, but it will continue into the vasa recta if we are in the juxtamedullary nephrons. It's based on where the nephron is ultimately located. Is it located in the cortex of the kidney, or the medulla, or the border of the medulla and the kidney? Anyways, efferent arterioles are responsible for playing a substantial role in tubular reabsorption and enhancing the medullary osmotic gradients. Here's some other principles you should think about as we go through this lecture today. To calculate your excretion of your urine, just use this formula. Calculate the filtration rate minus the reabsorption rate plus the secretion rate. Filtration is represented by step 1, reabsorption by step 2, secretion by step 3, and excretion by step 4. Okay, let's talk about the role of these arterioles in the glomerular filtration rate. So, glomerular filtration rate, or GFR, depends on the hydrostatic pressure in the glomerular capillaries, which will be determined by your afferent arterial tone and your efferent arterial tone. Afferent arterial tone controls blood entry, while efferent arterial tone controls blood exit. The way I remember what the efferent arteriole does is think about how it begins with the letter E, and the word exit also begins with the letter E. So, efferent exit. Okay, now let's think about the effects of afferent and efferent arteriolar changes on your GFR. So, when the afferent arteriole is dilated, this is obviously going to increase the renal blood flow and also increase your glomerular filtration rate. This is because more blood enters the glomerulus, thereby raising the capillary pressure. On the other hand, afferent constriction will lead to decreased renal blood flow and decreased glomerular filtration rate, as less blood will enter the glomerulus. Efferent constriction, on the other hand, when it's moderately constricted, this is still going to decrease the renal blood flow, because once again, we're constricting this part of the as a result will still be decreased. But on the other hand, the glomerular filtration rate will go up because the blood is backing up into your glomerulus, thereby increasing the hydrostatic pressure. Now, if the efferent arteriole is severely constricted, this is going to substantially decrease the renal blood flow even more. And interestingly, it's also going to lead to decreased glomerular filtration rate, as the reduced downstream flow will lower the filtration. So just remember the difference between moderate and severe constriction of the efferent arteriole. And then finally we have efferent dilatation. So this time the renal blood flow is going to increase as more blood is going to flow this way, and the GFR is going to decrease as the easier outflow reduces glomerular pressure. So now that we know how the changes to the afferent and efferent arterioles affect glomerular filtration rate, let's talk about some autoregulation mechanisms of these arterioles. So these arterioles play a key role in renal autoregulation, which involves the mechanism of maintaining GFR and renal blood flow across a wide range of blood pressures. First, we have the myogenic response, which is handled by the afferent arteriole. So this means that if there's an increase in blood pressure, this is obviously going to stretch the blood vessels. As a result, the smooth muscle is going to contract, and then this is ultimately going to protect the glomerulus from high pressure. So the afferent arteriole stretches, the smooth muscle in the afferent arteriole contracts, thereby protecting the glomerulus from the high pressure created by the increased blood pressure. And this is represented by the description here. There's also this mechanism called tubuloglomerular feedback, where the macula densa, which is part of the juxtaglomerular apparatus, will sense the increased sodium chloride delivery to, it's just going to sense the amount of sodium chloride delivery to distal tubuli. So here we have the juxtaglomerular apparatus, which has a macula densa, and it's going to sense the presence of sodium chloride in the distal convoluted tubuli. And if the sodium chloride level is high, it's going to signal the afferent arteriole to constrict, thereby leading to decreased glomerular filtration rate, because we don't want more sodium chloride to be filtered. Now, if the sodium chloride is low, this is going to lead to afferent dilatation or expansion of the blood vessel here. And so, what's also going to happen is that the kidney is going to release renin, and then there's going to be efferent constriction through the angiotensin II. So this will be constricted, and the net result of all these two processes is that the glomerular filtration rate will increase. So remember, these mechanisms happen if the sodium chloride level is low at the distal convoluted tubuli. And you can thank the macula densa and the juxtaglomerular apparatus for facilitating these mechanisms. We should also consider some pharmacology behind these arterioles, because several drugs indeed affect them. non-steroidal anti-inflammatory drugs will inhibit the production of prostaglandins. And because prostaglandins are normally responsible for vasodilation, NSAIDs will inhibit such process. This is going to lead to constriction of afferent arterioles, thereby decreasing glomerular filtration rate. And, oh yeah, I just said this earlier, but we can say it again. Prostaglandins, specifically PGE2, will normally dilate the afferent arteriole to maintain perfusion. So remember this molecule, PGE2. Then we have the efferent arteriole, where the angiotensin converting enzyme inhibitors, or the angiotensin receptor blockers, block the angiotensin 2. And this blockage is going to lead to efferent dilation and ultimately the decrease in glomerular filtration rate. This is clinically important, especially in cases of diabetic nephropathy and volume depleted states. And then we have some clinical scenarios that involve dysfunction of these arterioles. So, in general, for pre-renal acute kidney injury, this is often due to hypoperfusion, which can be due to hypovolemia. And the kidney will compensate this hypoperfusion through the afferent dilation and afferent constriction in order to preserve glomerular filtration rate. And so, if you give the patient NSAIDs or ACE inhibitors in such state, that can collapse or decrease the GFR significantly, thereby precipitating acute kidney injury. So watch out for the GFR. In diabetic nephropathy, this involves chronically high angiotensin 2 levels, which can lead to persistent efferent constriction. And as a result, you can have high intraglomerular pressure, which then leads to glomerular damage and proteinuria. And in this case, ACE inhibitors will be valuable because you can help to reduce this pressure, thereby protecting the nephrons from further injury. And we also have this thing called renal artery stenosis, where the reduced perfusion to the nephron is going to trigger the activation of the renin-angiotensin-aldosterone system, which leads to constriction of the efferent arteriole to maintain GFR. On the other hand, if someone is prescribed with ACE inhibitors and also has renal artery stenosis, this can be dangerous in that ACE inhibitors can drop GFR precipitously, especially if bilateral renal artery stenosis is present, and a significant drop in GFR can thus lead to acute kidney injury. So, those are some clinical scenarios to keep in mind. And then for histology and cellulology, we have that both arterioles are typically lined with endothelial cells and would be surrounded by smooth muscles. As kind of indicated over here, the afferent arterioles will have the juxtaglomerular cells that secrete renin in response to the sympathetic stimulation via the beta-1 receptors. Decrease renal perfusion pressure or low sodium chloride sensed by the macula densa. And then, as we go down, there's some ways in which this can be integrated with systemic hemodynamics, where the afferent systemic blood pressure because the kidney receives about 20 to 25% of cardiac output. You can thank the renin-angiotensin-aldosterone system for this integration. And then volume status, sympathetic tone, and systemic vascular resistance ultimately interplay with renal arteriolar tone, which is why the kidneys are fundamentally important in hemodynamics and the cardiovascular system. So in summary, afferent arteriole head towards the glomerulus, while efferent arteriole goes away from it. Afferent arteriole affects renal blood flow and GFR, while efferent arteriole primarily affects GFR. The receptors involved in afferent arteriole include the beta-1 receptors in the juxtaglomerular cells. It is also prostaglandin sensitive. While for efferent arteriole, it is sensitive to angiotensin II. The drugs that affect afferent arteriole are your NSAIDs and the prostaglandins. And then for efferent arteriole, it's your ACE inhibitors or angiotensin receptor blockers, while angiotensin II is responsible for constricting it. And then pathologies involved include NSAID-induced acute kidney injury because NSAIDs constrict the afferent arteriole, thereby decreasing glomerular filtration rate. And then for efferent arteriole, it can be ACE inhibitor-induced acute kidney injury and renal artery stenosis, along with the occurrence of diabetic nephropathy due to the chronic constriction of the afferent arteriole. And so, some clinical pearls to think about are, when you evaluate changes in kidney function, always consider how the afferent arteriolar tone might be affected by hemodynamics, like hypovolemia, medications, hormonal factors, and local regulatory mechanisms, as mismanagement of these can lead to preventable renal injury. So that is it for today's video. And, well, actually, one more thing. If you're curious about the histology of the glomerulus, you can see that these are the mesangial cells, and then your red blood cells, as visible over here, surrounded by the filtration membrane. And then you sometimes can see the capillary endothelium in a clear and conspicuous manner. And then, obviously, the surrounding structure is a Bowman space or capsule. And sometimes you can see the podocytes. And here is another view of the glomerulus. Looks like the filtration membrane here is more conspicuous, so that's good. You can also see the distal tubuli with the macula densa present. And then this must mean that this must be the start of the proximal tubuli. And of course, this would be the basement membrane and the epithelium of Bowman's capsule. So yeah, that's the histology behind the glomerulus.